Arjun, Medicine Safety Officer at NELFT.
Fantastic. So that's the NELF team. So just to give a bit of context, we've got a short session on benzodiazepines and Z drugs. It's very topical in the agenda. It's part of the national agenda as well. Obviously, as you're aware, it's a drug of high risk and dependency. So we're going to open up with a presentation presented by Ishraq and Priyanka. And there's also going to be some case studies and also an opportunity towards the end for discussions, questions and answers. So over to Ishraq and Priyanka. If you have any comments or questions, by all means, put them on the chat. But while the speakers are talking, we'll be taking questions towards the end, please.
Thank you. Sorry, Ishraq, I was just going to ask if we need to record the session as well.
Yes. Kylie, is that from your end?
Yeah, it's currently being recorded as we speak.
Brilliant. Okay.
Brilliant. Thanks, Isabel.
I'm going to try to share my screen because I've opened it through the web browser. There wasn't any other way. Windows. You're going to see all your faces soon. Can everyone see that?
Yeah.
The primary care learning event?
Yeah, we can see it.
Thanks, Priyanka. So this session is about benzodiazepine and Z drugs in terms of their prescribing and withdrawal. So like I said, we're going to discuss about a few, case studies, and it will be quite an interactive session as well. So if I could ask everyone to scan this QR code for me. So we do a little quiz in the beginning. So I'm just going to switch my screen over to the Mentimeter. How many players do we have? Go next. We've got 2. So once we get about 10, I'll start. Actually, did I allow people enough time to? You could use this code as well up here: 31423610. Got about 8 players, so that's fine. So I'm just going to start the questions. So there we go. So in October 2013 alone, how many prescriptions were issued for benzodiazepine and Z drugs by GPs in northeast London? So you've got about 15 seconds to answer that. So everyone's voted. So so the number of prescriptions that was actually issued then was around 18,600, and we'll talk about the stats later on of what that means. And we're going to go on to our second question. We've got more players now. So in 2022, what percentage of deaths related to drug poisoning in England and Wales involved benzodiazepines? Again, at 15 seconds. So everyone's voted. Should pop up.
Oh, yeah.
So majority of you got that right. So actually, it was in 2022 there was reported to be about 18% patients who died from drug poisoning from benzodiazepine. And again, we'll go into those stats now in terms of their significance. So this is where we've got the data from. So you can get the data from Open Prescribing yourself. So in terms of the number of prescription, as you can see in 2018, the number of prescription of benzos and Z drugs that were given out was higher. So it was around about 24,000, and now the latest data shows that only 18,000 prescriptions were dispensed. So there has been quite a big reduction in the number of prescribing of benzos over the past 3 to 4 years. So it's a good sign. And as well, it's in line with the national data as well, as you can see with the table. And so on the right-hand side is the number of deaths with these with some of these. So I showed a couple of examples of other drugs as well, some of the opioids and other drugs that patients can misuse. So cocaine is the highest in terms of the number of percentage of deaths. And I was quite surprised to see that benzodiazepine was basically the second highest. And that's slightly creeping up over the past 10 years as well. So that's for both groups, males and females. So yeah, so that's with the SATs. And Priyanka, your...
Thanks, Ishraq. So, yeah, that was really good to just see kind of what the issue is, what the problem is, which I'm sure you're all finding in your GP surgeries too. So we thought we'd start with just a quick introduction of what are benzodiazepines and Z drugs. So we know that benzodiazepines are GABA receptor agonists. They're actually grouped into two kind of classes of hypnotics and anxiolytics. So kind of in the name of how like hypnotics are there to help with sleep, so the short-term treatment of insomnia, anxiolytics to help patients who are having different forms of anxiety. Ideally, benzodiazepines and Z drugs, they would be used in short-term crisis presentations, and that's one of the key messages from today. That is one of those medicines that it should be used for short-term. We've got Z drugs as well, which are non-benzodiazepine hypnotics. Mainly to help with sleep. It's pretty much only indicated to help with sleep. And the only two available in the UK are zolpidem, zopiclone. We've just got a list of all the Z drugs, essentially. Even chlordiazepine is one of the benzodiazepines too. Next slide, please. So the place in treatment, so as we mentioned, it's for insomnia or anxiety disorders. So what we would do is kind of prescribe benzodiazepine Z drugs in a stepwise approach. So with insomnia, the first step wouldn't be to, prescribe a medicine straight away. We look at any contributing stresses for the patient. Are they going through is there any situational things going on, financial troubles, any deterioration in their mental health? Maybe they've got depression or any deterioration in any other mental health conditions. Look at offering sleep hygiene techniques. And then if this is very debilitating for the patient, it's affecting their daily life, we may consider giving Z drugs. Probably about 3 to 7 days for an acute distress, because soon you'd expect the symptoms would be likely to resolve. Now, and that's just to help them kind of get about with their daily routine. CBT is another option as well for insomnia, which is also being kind of used a bit more often nowadays. We've also got the using Z drugs for a longer course, or even melatonin, melatonin is only licensed for those over 55. Ideally for maybe up to 2 weeks, maybe as an adjunct for acute distress where symptoms are likely to persist. We've got where it could be used in anxiety disorders. So first step for if someone's got anxiety, we'd look at, can we provide them any psychological support, any support through therapy, any techniques, coping mechanisms to manage it. Another way is using SSRIs, so sertraline or fluoxetine, followed by an alternative SSRI or SNRI if that hasn't worked. Pregabalin's an option. Now this is third line, or looking at other further specialist pharmacological options. And benzos, we'd say it's only meant to be used for a short term in a crisis situation. So one thing that NICE does recommend is that if someone's got ongoing insomnia, that CBT for insomnia is actually meant to be first line. And what we generally advise is use the lowest effective dose of the medicine for the shortest period possible, PRN where possible as well. We don't want patients to become very dependent on it. Next slide, please. So cautions and contraindications. So this is information that you can find from the SPC, BNF, but we thought we'd just outline them here, that these are the kind of patients who we shouldn't be prescribing benzos or Z drugs for. So people with acute porphyria, so that's one of the blood disorders that could be triggered actually by certain drugs. So it's useful to obviously monitor patients once they start a new medicine or a new benzo. Myasthenia gravis, so a neuromuscular disorder that leads to weakness. The condition could be aggravated if you give someone with benzodiazepines. Then you've got sleep apnea. This is quite a common condition. We do see quite a bit in patients with mental health conditions as well, that if they've got sleep apnea, benzodiazepine should be completely contraindicated and not used because the condition could be aggravated. Severe hepatic insufficiency, and chronic psychosis or depression, where benzodiazepines or Z drugs would be used alone. We wouldn't expect patients who have got chronic psychosis to be reliant on just benzos or Z drugs. Next slide, please. So, so we're looking at the long-term risks of benzodiazepines. So one of them is cognitive impairment. It could affect the patient's memory. This might even persist after patients have withdrawn from the benzodiazepines. We've also got increasing risk of falls, especially for the elderly, road traffic accidents. As you know, benzos and Z drugs can make patients quite sedated. So if patients have been on these drugs for quite a long time, it's actually affecting them throughout the day when they're driving, and they're actually feeling sedated. This could be very dangerous for patients who are continuously driving. It could actually cause aggression, lead to depression and anxiety for patients on it for a long time. Patients could feel quite impulsive. A big one is addiction and tolerance. And as we know, there have been cases of patients being poisoned by this from an overdose. It is quite common to see patients being admitted from A&E or to the inpatient wards because of an overdose of benzodiazepines or Z drugs that they've had. Essentially, it may have been stockpiling. And significant withdrawal can occur. So the longer you have been on these benzodiazepines, the withdrawal process is inevitably going to be longer as well, and it could take a longer time just because of this type of symptoms patients are experiencing. Next slide, please.
This is my turn. So the final question on that Mentor.me, we're going to go back to the quiz. So just going to pop that up again. Hopefully everyone's. So if everyone can just write down 2 common symptoms of benzodiazepine withdrawal. Should give you options to write down on your phones. Yep, that's right. Nausea and headaches. Yep. Looks like you guys already know it. Any more? Yep. Fine. Yep, you guys got majority of those down. So I'm just going to go back to the slide.
Well done, everyone. I think that we've covered quite a few of the withdrawal symptoms. So we've got, it's cast into 2. So the physical withdrawal symptoms, so they might feel like they've got the flu, feeling quite run down, some gastrointestinal symptoms of nausea, vomiting, generally feeling quite unwell, getting seizures. This is quite rare. Abnormal body sensations, muscle cramps, aches and pains, and the psychological symptoms. This may affect patients a bit more. So if they've already, and someone quite rightly said, it could worsen their initial problem. So if someone's already quite anxious, this could actually make their anxiety even worse, make them more agitated, cause insomnia, paranoia, and obviously this can be quite debilitating for someone. It could affect their work, their daily life, and it could get quite concerning if they then become a risk to themselves or other people. So it's just important to know that obviously when we have to counsel patients on what the withdrawal symptoms are before, you decide to wean someone down, just to explain that these could be mild, very short-lived. It doesn't mean that all withdrawal symptoms will be very severe or long-lasting. It just depends on how long that patient's been on the benzo or Z drug for. It's more likely to occur with short-acting benzo, so diazepam, rather than the long-acting ones like diazepam. Seizures, delirium, psychosis could also occur, and that's usually from very rapid withdrawal, so that's why we will be talking about how you can withdraw patients carefully. And just another thing to consider is one of those withdrawals could possibly be even suicidal ideation. So it's just important that, once you decide that you are going to withdraw someone from benzodiazepines, the timing that you're going to do it, if they are someone who has previously had made suicidal attempts or had these ideas for it, just to make sure you know the kind of any triggers, any relapse signs as well, but just to look out for the signs. And I will hand over to Ishak for the next part.
So we're going to talk about the good prescribing practice when we're initiating these drugs. So it's important that we give the patient's carers enough information to make that sort of informed decision. So any potential side effects, the possibility of dependency, and symptoms that suggest that development of problems associated with dependence. There are good resources out there that you can give to patients. So after this session, I will be sending the benzo guidance to everyone, which has a really good patient information leaflet. It's a good reminder to healthcare professionals as well of what some of the issues and what it's been used for. So it's making sure that they have all the information there at the point of prescribing. And another important thing is that when we do prescribe these drugs, it's important that they let. So if the patients, a lot of patients will obviously drive, so it's important they actually let the DVLA know that they're taking these drugs. Because there was a law that came into force in 2015 where a police, if they do stop you, they could monitor you for levels of benzodiazepine, and if it's above a certain limit, then it's considered driving under the influence as like alcohol. So it could be a criminal offence. So it's important that they we tell them that it could affect their driving, and they let the DVLA know. So that's something a lot of people forget to tell their patients. And benzos and Z drug, it should be prescribed in accordance with their license, dose and duration, and ideally they shouldn't be continued beyond the license period without documentation of valid reason. So again, maximum 2 to 4 weeks. Because research, clear evidence shows that if you're going to use it more than that, then they're already going to start building up the tolerance and dependence. That's why it's quite important that it's only used for a short duration of time. So again, the reason or rationale for prescribing those drugs should be documented in the patient's notes, so they're electronic notes that you guys use. And if you are prescribing a Z drug, don't go straight to 7.5 milligrams of Zopiclone. Start on 3.75 on when required basis. So when you do prescribe these benzos, it's important that you want to review these papers regularly, and ideally, depending on the patient, every 2 to 4 weeks. And this will ensure that the patient doesn't go on to be on, Zopiclone for the next for the next 2-3 years. So it's important that we monitor these patients regularly, ideally about 2 to 4 weeks. And when you are prescribing these drugs, it's important to include the following: so the indication for use, the rationale if you're prescribing outside the license indication, the expected duration of that treatment, when the treatment is to be reviewed, who's going to review that treatment, and who you're going to contact if a problem does arise. And where you do prescribe these drugs, there should be also a clear plan of how you're going to also take them off of the medication as well. So a suggested tapering regimen. So the next slide is just an example of what that looks like. So, you plan to start Mr. S on diazepam on 2 milligrams BED for anxiety. The expected duration of treatment will be 4 weeks. The patient will be reviewed maybe once a week, or it could be 2 to 4 weeks by this clinician. If a problem arises, please contact so-and-so. And then once the patient is well and stable after a treatment period, consider a gradual reduction. So I've listed, so I've just gave an example here of a diazepam reduction regimen every 2 weeks, but it should be tailored to the patient. You might notice they might not tolerate every 2 weeks. It could be monthly, or it could they could tolerate a much faster titration, down titration. But this is just an example. Again, throughout this reduction, they should be monitored regularly after each reduction period, and if symptoms relapse, consider maintaining the current dose for a further 1 to 2 weeks and slower the rate of tapering. So this is just an example of what good documentation looks like when we are prescribing these drugs. So the next thing we're going to talk about is, so we talked about the good practices, but next we're going to talk about the withdrawal. I think there's a bit of background noise. Someone can mute them for me. Withdrawal pre-assessment. So again, when I do send the guidance over, it will have this in a bit more detail what you need to do. But essentially, is now the right time to start that withdrawal for that patient? If you find patients once you do identify patients who've been on these drugs long term, so are they willing to come off of it? Are they committed? And how are they psychologically? How's their mental state? If they're in crisis or they're still quite unwell, then I wouldn't advise a reduction at this point. You want to get them stable first before considering a reduction, because as I said, that if you're going to do this reduction, the withdrawal symptoms are just going to add to their current mental state, and the patient could further deteriorate. So I would only advise those who are stable to consider that reduction. Also, the thing to consider: can that withdrawal be done safely, supervised in a community setting? So again, do you have the resources to monitor this patient every 2 to 4 weeks? So can it be done? Do you have the resources? So that's one important thing to take into account. Are they using any other substances like alcohol or drug use or other recreational drugs? You may have to consider referring that patient to the drug and alcohol services who can help with patients who do take recreational drugs or alcohol. So the patients could either self-refer themselves, or you could make that referral. So each 4 boroughs should have a drug and alcohol services that you could refer these patients to. And finally, any medical issues as well. So if they suffer from epilepsy, then you don't want to take that. You don't want to start discontinuing that because it's licensed to be used in some patients for patients who suffer from epilepsy. So that's that. So again, this is an algorithm of how to withdraw patients. Like I said, this will be in the main body of the guidance. There'll be a bit more detail. I've just taken a snapshot from it. So first thing you want to see is, why is the patient taking this drug? If it's for other sleeping disorders, such as restless leg, if they're acutely unwell or in crisis, so those who are manic or psychotic, for those who suffer from alcohol withdrawal or epilepsy, then the advice is to continue the benzodiazepine. I do want to emphasize this, though. I know this is showing that, how benzodiazepines have do have their place in treatment. So when a patient is, for example, in crisis, then we do recommend prescribing this. We need something to calm down the patients, and benzodiazepines are excellent at doing that. So they do have their place in treatment. It's when you continue the treatment for a period of time, that's when it becomes problematic. For example, because one other issue with benzos in the long term, when you're treating someone who's come onto, like, let's say, the inpatient ward, who's acutely manic or psychotic, you start them on, let's say, clonazepam. They calm, it has the calming effect. They become stable, and you start them maybe on a mood stabilizer or antipsychotic. So when what I advise my consultants on the wards is try to stop the benzos before they get discharged, because another issue with benzodiazepine is that they mask symptoms. So that masking effect, so we don't know if the actual antipsychotic or mood stabilizer is actually working, or you've just sedated that patient with benzos and they're just sedated, so they can't. And then what you might find is when you start to taper them off the drug, they start relapsing. So that's another problem with long-term benzos, is they mask symptoms. So that's another important thing to take into account. But for those four, you want to continue benzos. And only are right if they're suffering from chronic insomnia, they're using it for recreational use. For those aged over 65 years, regardless of how long they're taking it for, and for those aged between 18 and 64, and for taking for more than 4 weeks, then we would recommend the de-prescribing. And the next step will be engage the patient. So like I said, mentioned before about the pre-withdrawal assessment, this is when you start doing it. So you're discussing the potential risk, the benefit, the withdrawal plans, and their symptoms, and seeing if it's ideal to start the de-prescribing now. So that will be the first bit. And once everything's fine, then you go to the next bit, which is start tapering them off of these drugs. So I've categorized it into two sections. So you've either got your low-risk patient or your high-risk patient. So your low-risk patients are those who have been taking benzos for less than 6 months, and they're on a long-acting benzodiazepine, and they haven't had any previous significant withdrawal symptoms in the past. Then you can make like a test reduction of 25% of the current dose, and thereafter by 12.5 every 1 to 2 weeks. Does anybody know any examples of any long-acting benzodiazepines? It's a question. Any examples that you think that are long-acting? Have a long half-life? You guys can still hear me, right?
Yeah. Anyone, you can shout out or put it on the chat.
Yeah. Sorry, you could put it on the chat. I won't be able to see it, but
We've got one diazepam from Atiba.
Yep, that's correct. Any more?
Nitrazepam? Any more?
Any more? That's correct. Nitrazepam, sorry. There's two more.
Clonazepam?
Yeah, that's right. There's one more left that you might commonly see. You see it in alcohol. Someone suffering from alcohol to treat alcohol withdrawal, usually in hospital. They get admitted.
And chlordiazepoxide.
Yes, that's it. That's another long-acting one. And any examples of any short-acting benzos?
Lorazepam?
Yep, that's right. That's short-acting. Any more? So it's a quick one. So all your Z drugs, they're all short-acting. And all the other ones that you haven't mentioned are probably short-acting as well. So your lorazepam, your oxazepam, your temazepam, they're all short-acting. So now we can go to the high-risk patients. So the high-risk patients are those who've taken benzos for more than 6 months and who are on a short-acting benzos, as someone mentioned lorazepam, for example, and they've had withdrawal symptoms in the past, then the reduction will be would be much slower, and the percentage of reduction will be much lower than those who are on low risk. So about between 5 to 10% of the original dose, and thereafter you want to reduce by 5 to 10% every 2 to 4 weeks. I just want to state here that this is just a guidance. So again, it should be tailored to the patient. So you might find that even the low risk might not tolerate that, and you might have to do a slower reduction. It could be every month or every 2 months. And what I do want to say that it can take a long period of time to get patients completely off of benzodiazepine and Z drugs. I have quite a few patients under my caseload that it's taken one patient that it took up to nearly a year to get him off diazepam, and he was only on a small dose, but we just had to be quite gradual with him because he did have quite bad withdrawal symptoms even with diazepam. So again, like I said, this is just a guide, but it should be tailored to the patient. So the next step, so once you make that first reduction, you want to monitor that patient every ideally 1 to 2 weeks after that reduction period. And there is a tool that you could use that I'll discuss further. Also using non-drug approaches to treat their insomnia. So as Priyanka mentioned in her previous slide, looking at sleep hygiene, relaxation techniques, and CBT. And those are first line for someone who's suffering from insomnia. And again, as I've mentioned before, if they do relapse, then we, in terms of if they do have really bad withdrawal symptoms, then we might have to consider increasing the dose slightly and maintaining and doing a reduction at a much slower rate. So that's that. So again, monitoring. So as I've said before, after each reduction, you should be monitoring that patient in 1 to 2 weeks' time. And that monitoring, that monitoring may take in the form of a simple measure of symptoms each day. So there's something called a CWB, so it's a benzodiazepine withdrawal scale that you could just, it's just a tool that you could use to quantify like how bad the withdrawal symptom is it mild, moderate, or severe? And for patients misusing other substances, such as opioids or alcohol, they should ideally be seeking support from the drug and alcohol services, or we could also make that you could also make that referral to them as well. But it's important that the patient engages, because if they don't engage, then they won't provide any support. This is what the withdrawal scale looks like. It's a bit blurry here, but when I do send the guidance, it'll be much clearer. Like I said, it's all these questions, and then you sort of rank them out of 0 to 4, and you work out the total, and then at the bottom it'll tell you if it's mild, moderate, or severe. And for those patients where the symptoms are mild, then you could continue with the withdrawal regimen as how it is. It's when we go to moderate to severe, that's when we got to think about maybe slowing the rate of tapering, or even increasing the dose slightly to help them manage with the withdrawal symptoms. And yep, that's it for me. And next we're going to talk about this case study.
Thanks, Ishak. So yeah, we've got a case study for you just to kind of bring everything together. So this is typically maybe a type of case we may get in our community mental health teams where me and Ishak work. So just a bit of background: this patient who's 28 years old, male. They've got worsening anxiety and depression, and it's associated with poor sleep. So they're only on sertraline at the moment. They've got no past medical history, non-smoker, nil illicit substance use. One important thing to consider is they've got an intolerance to zopiclone. It causes nausea. Next slide, please. So the doctor, the pharmacist, usually, typically they may work together as well when we review patients, make a management plan. So they think about adding a sedating antihistamine, such as promethazine. That's one option. We could add a short-acting benzodiazepine because we, have noted that he's got an intolerance to Z drugs. So after the patient's reviewed, they're started on lorazepam, 2 milligrams at night, and they improve over the following weeks. And then the following is now written in the care plan that's sent to the GP regarding lorazepam. And that's typically in the clinic letters, which a community mental health team doctor may send to the GP. Next slide. So they've written patient sleep and anxiety have significantly improved on lorazepam. The conditions is to continue the lorazepam 2 milligrams at night and review. So what I'd like to ask is what is actually wrong with these directions? So feel free to shout out or put it on the chat. There's quite a few things wrong in this. So this is if you receive this from in a clinic letter at your GP surgery and you're reviewing it. What do you think's wrong? Okay, so one person said in the chat, there's no information on treatment duration. There's no information when to review. Yeah, that's absolutely correct. So we're thinking of timelines as well. Someone else has said, yeah, the term review is very vague as to duration. And that's absolutely right. We would try to expect someone to have an actual timeline because with benzodiazepines, obviously it's recommended for short-term use, but short-term is different for every patient. Anything else? That this is what you would expect if you received a letter. There's no reduction plan yet. That's right. So, how would we know how to reduce it? And we know that having that clear, just like the example before, just having a clear stepwise approach is quite useful. So everybody's on the same page anymore? No? Okay. So we can move to the next slide, please. Okay, so this is, all the suggestions are very good, actually. There were just a few that were missed. So this is, if we're transferring patient care to primary care, we'd look at the indication for use. So we'd want them to write that the lorazepam is being used for, is it being used for sleep? Is it because of an acute crisis of anxiety? The rationale if they're prescribing it outside the licensed indication. The expected duration of treatment, which was rightly said, when it will be reviewed, who will review it as well. Sometimes, if they're expecting the GP to review it, that would be quite useful for them to explicitly say that. Or are they due to have an appointment with their CMHT doctor soon and they will be reviewing it? If a weaning regimen has been agreed beforehand, what would that look like? So detailed as Ishak had in his previous slide. So including monitoring, reviews, so when is the monitoring, how is the monitoring occurring, when are the reviews, and who to contact in secondary care if there's a problem. So we've obviously got the patient's consultant, their doctor. Just so you're aware, I'm sure most of you are aware that some patients who are under the community mental health teams may have care coordinators. Now, this is an allocated healthcare professional. It could be a nurse, a social worker, who is that patient's kind of first point of call if they've got any kind of deterioration in their mental health. And usually that person's name would be on the clinic letter, so that might be someone to contact if you needed some more information about the patient. So thanks everyone for engaging. So next slide, please. So just continuing on, so lorazepam does get continued by the GP, but the patient then gets referred 2 months later following an abrupt discontinuation by the GP. And just a reminder, they were on 2 milligrams at night. Although that's not the maximum dose is 4 milligrams a day. However, it is quite, a substantial dose. This patient was having severe anxiety. We noticed he already had a form of anxiety when that was his presenting complaint, so that got heightened. Nightmares, cramps, headaches, and it becomes pretty unbearable for the patient. So lorazepam is restarted to help with these symptoms and upon request of the patient. And even though he's keen to stop, he just feels he cannot continue with these type of withdrawal symptoms. So what do we do next? Next slide. So what we consider doing, there are a few options. One would be, as we said previously, obviously the patients on lorazepam could look at titrating the lorazepam down slowly. However, because we know lorazepam is short-acting, one option is switching it to lorazepam, which is more longer-acting, the equivalent dose, and down-titrating this gradually. If we could have the next slide, please. So this is just an example of a weaning regimen and how to monitor. So as you can see in the table, the lorazepam 2 milligram dose that the patient's on is actually equivalent to diazepam 20 milligrams. So this is an example of something that may occur in the CMHT or the GP, and it's just giving an example of how to reduce it. Obviously, just remember the timelines might be slightly different. It may be weekly if you are able to see the patient that often, or it could be 2 weekly. But one option is actually splitting that dose of lorazepam. So it was 2 milligrams at night. If we did it to 1 milligram morning and night, but actually converting the morning dose to diazepam. We've got diazepam 10 in the morning, then 1 milligram at night. Then by the second week, look at converting the remaining lorazepam to diazepam. You've got kind of a slow switch of this diazepam. Then by week 3, looking at reducing the diazepam slowly by 5 milligrams. And then we'd expect if you could, write a kind of, as we wrote before, of every week or every 2 weeks or whatever the timeline is, how much is being reduced, and make sure this is reduced in agreement with the patient as well. Looking at their withdrawal symptoms to be monitored every week using the CEWA scale that Ishrak mentioned earlier. However, just, I'm sure you will know as well that all of this depends on how much the patient engages as well. So if you have someone who is very keen to reduce their benzodiazepine, someone who's very vocal about if they're getting side effects, then this will be quite successful. So it's just obviously important to just tailor this depending on your patient, and every patient is quite different. Next slide, please. So these are just the key messages to take away from the presentation, is that where benzos and Z drugs are prescribed, it's just to note that this should be for a short duration. So anytime you see it on somebody's record, just to have a look at, for example, how much are they being supplied with? That's another thing. And how long have they been on this for? Because it could be something that if you notice something quite alarming, to flag up to the GP, flag up to the community mental health team as well. I think that's one of the main key messages here. And review the indication for any new or pre-existing benzos. And this could just be as simple as when you've got the review with the patient, just to ask them, what are they taking it for? Because sometimes you come across patients who don't actually know why they've been on it. It's been continued and not actually reviewed. Counsel patients when they're starting it, just make sure that they're well informed now that we all know, what the risks of long-term use are for patients, and just so that they're well informed right from the start that this is a short-term course. Dependence is likely, but it's just so that they don't have the idea that this is the cure to everything at the start. Next slide, please. Just the last few key messages is that ensure there's a stop date agreed for if a benzodiazepine is started or a Z drug. So if it is, started and they say within 2 weeks, we're just going to give you this much, it's going to stop. And if there's a clear management plan written up, if a stop regimen is required, and patients who are on long-term medicines, just to make sure that they are reviewed, that there is something in the notes that this has actually happened. It's good to engage the patient to discuss their indication, the risks, the benefits. How can we optimize their medicines in general, the withdrawal plan? And I do understand it is very difficult to sometimes engage patients in this discussion, because as soon as you mention it, some patients may be very reluctant to even talk about it, to explain why they're on it. They may say, this is what I want to continue with. It helps me with my anxiety. I take it when I need to. But I think our main aim is obviously making sure that they're well informed of these long-term risks as well, that there is, a big initiative with benzodiazepines and Z drugs to monitor it more closely, just because of obviously the recent news has been on it, the safety risks. So I think the main thing is that you've had that conversation with the patient and you do signpost or flag up to any other healthcare professionals that it's required to. So this is the end of our presentation. Thank you all for listening. These are some references as well, and we will send around the guidelines. Please let us know if you've got any questions.